Hi, I'm Rosina Badal Munir, and today we will learn the neonatal head sonography. In neonatal head, there are different acoustic windows to look for the intracranial anatomy. The most commonly used window is the anterior fontanelle, and additional windows is the posterior fontanelle, the temporal window, which is in front of the ear, and the mastoid window, which is at the back of the ear. Brain is divided into three main sections. The cerebrum, which consists of the most cephalic portion. It consists of two cerebral hemispheres, the left and the right, and these are divided by the falx cerebrum, which is the midline in the center. The second part is the hindbrain, which is located below the cerebrum. Cerebrum is also called the forebrain. So the hindbrain, which is also called the cerebellum, it is lying below the cerebrum. The brainstem is the third part, which is lying behind the cerebellum. Look at over here, and it runs along the spinal cord. Now coming back to the cerebrum, which is called the forebrain. Now the forebrain is divided into folds and ridges, which increase the surface area of the brain. Now each cerebral hemisphere is further divided into four sections. The frontal lobe, which is separated from the rest of the lobes by a sulcus, which is called the central sulcus. The temporal lobe is separated from the rest of the lobes by sylvian fissure. Sylvian fissure is also called as lateral sulcus. The other two lobes are the parietal lobe, and the most posterior one is the occipital lobe. So the anterior one is the frontal, the posterior one is the occipital, the lower one is the temporal, and the upper is the parietal lobe. The cerebellum, which is the hindbrain, it is divided into two cerebellar peduncles, and the central part of it is called the vermis. So on the neonatal head, if you can see, the frontal part, which is above the forehead, is the frontal lobe, is the frontal bone, and below that is the frontal lobe. This is the area of the parietal lobe. This is the area of the temporal, and the most posterior part is the occipital lobe area. The key sonographic structures required for the evaluation of the neonatal brain are the interhemispheric fissure, sylvian fissure, cavum septum pellucidum, corpus callosum, basal ganglia, and ventricular system, and the cerebellum. To assess the intracranial anatomy, coronal and sagittal views are taken. So in coronal view, 6 to 8 standard views are taken starting from the anterior to the posterior to look for the intracranial anatomy. Put the probe in the anterior fontanelle of the baby with the probe marker facing towards the patient or the baby right side. On the first image, adjust the depth, gain, and TGC settings. The image should not be too bright or too dark, and the image should fill the monitor screen. Angle the probe anteriorly towards the anterior cranial fossa to obtain the first anterior coronal view, which is also called as prefrontal view image. Manipulate the transducer to obtain the symmetric views. Identify the interhemispheric fissure, which divides the two cerebral hemispheres. Freeze and annotate the image. The prefrontal image reveals the frontal lobes of the cerebrum and the orbital bone. The high resolution image of the brain shows the normal appearance of the sulci, which appears as echogenic lines, and the gyri, which appears as the darker area. By angling the probe slightly posteriorly, the second coronal image will be at the level of the anterior horns of the left ventricle, the cavum septum pellucidum, the corpus callosum. So note the echogenicity of all the parts of the basal ganglia. You will see a star-shaped structure in this view. So if you put the color Doppler on these star-shaped structures, you will see the circle of Willis, which consists the most prominent vessel you will see and recognize will be medial cerebral artery. So look at over here. So this is the basal ganglia area. This is the cavum septum pellucidum. This is the lateral sulcus or the sylvian fissure, interhemispheric fissure, and this structure in between is the this C-shaped structure is the corpus callosum. So in the second image, you need to identify all this anatomy of the brain. So this is another view at the level of the cavum septum pellucidum. So if you look at over here, the midline CSF filled structure between the two anterior horns of the lateral ventricle. So these are the two tiny lateral horns of the anterior horns of the lateral ventricle. So this they all have a free CSF, cerebrospinal fluid, so that's why they look anechoic. Right above the cavum septum pellucidum, you see this small tiny portion, which is the corpus callosum. Below the cavum septum pellucidum, you see another small tiny anechoic area, and this is the third ventricle. The lateral ventricles are larger in the preterm infants than in the term infants. The asymmetry between the lateral ventricles is common, and it is not necessarily the abnormal. Even if you look at over here, there's a little bit asymmetry. The cavum septum pellucidum is also often larger in the preterm infants, and it is filled with the CSF, but it is not communicating with the ventricular system. And right above that, you can see the corpus callosum. Now when you move your probe a little bit more, angling towards the posterior direction, so this is at the level of the tentorium. So look at over here, you see these nice C-shaped structures. This is the level of the tentorium, and look at over here the corpus callosum. So this is over here. If you look at over here, this is the closer look of the corpus callosum. So look at over here, and this is the sagittal view of the corpus callosum. A corpus callosum is a horizontal bundle of nerves which connects both the left and right cerebral hemispheres, and it is responsible for the communication between the left and right cerebral hemispheres. So if you look at over here, this is it is type of a bridge between the two hemispheres. And it is divided into different parts. So it is this part, which is the most anterior part, is called the rostrum. Then is the genu, and then is the body, and the back part or the tail, which is called the splenium. So this is the entire appearance of the corpus callosum on a sagittal view. So this is the gross anatomy shown as corpus callosum, because it is very important to see and look for the corpus callosum in both the coronal and the sagittal planes. This is another image showing at the same level of tentorium. So look at these structures, which are the tentorium, and you can see these are the structures over here. So now you start with the appearance of the cerebellar peduncles over here. The center part is the vermis of the cerebellum. And if you see over here, the small posterior anechoic structure, this is the cisterna magna. So this is the gross anatomy. That is how the brain looks on the ultrasound when you are scanning. Throughout the image, keep an eye on the interhemispheric fissure so that the line should be regular and it should be right in the midline. So by more posterior angling, you will see these small 3 little dots. If you look at over here, these are the small 3 dots. Actually, these are the choroid plexus. So this is the choroid plexus, which is seen at the posterior horns of the lateral ventricle. And this small dot, which is echogenic, is the choroid plexus in the third ventricle. So this is all this image, or when you see this kind of image, so it means that you are at the this 3 dot sign is shows you that you are at the level of the posterior horns of the lateral ventricles. The structures which is on the below the lateral ventricle, it is the thalamus. So look at over here. This is another. This is a little bit more angling posteriorly. You will see this tree-shaped structures, and this is again the vermis of the tentorium vermis. And now you can see the lateral ventricles, and these are the choroid plexus. Now angling further posteriorly at the level of the trigones, which is also called the atria of the lateral ventricle, you will see this choroid plexus, which fills the lateral ventricles This is the view at the level of the trigone. So a few words about the lateral ventricles. So this is the lateral ventricle. It consists of the anterior horn, the inferior horn, and then the posterior horn. So all these three horns combine and meet at an area. So junction area, or the common area of these all three horns, is called the trigone or the atrium of the lateral ventricle. And this is the part where you see the choroid plexus. So look at over here. So when you see this appearance of the choroid plexus, so you are at the level of the atria or the trigone. Choroid plexus is prominent in the preterm infants. So the choroid plexus hemorrhages may be difficult to differentiate from the bulky normal choroid plexus. Sometimes the white matter around the lateral ventricles appear quite equidense. They appear a little bit more prominent. So if we look at over here, and this is called the periventricular white matter or periventricular blush. Look at the symmetry and the density of this white matter. It should not be more than the choroid plexus density, which means that it should be less brighter than the choroid plexus. So when you see this periventricular blush, so pay a little bit more careful evaluation of this area. Now, by angling the transducer even more posteriorly results in the image that will slice the brain above the level of the lateral ventricles. So in this plane you will see the occipital cortex, which may be visualized. So you will see over here, this is the occipital cortex, and you will also see the parietal lobes, and you will see the periventricular white matter or the periventricular blush more prominently in this view. So this echogenic area represents the vascular markings as well as the neurons which are extending from the deep white matter to the cortex. So look for any abnormality or any asymmetry or any cystic cystic changes in this white matter. For Sacher scanning, rotate the probe 90 degrees with the marker on the probe facing towards the baby face. Now the Sacher scan starts from the midline, which passes through the interhemispheric fissure, and then the second line passes through the cordothalamic roof, and then it passes through the white matter. So usually, you take about 4 to 5 or 5 to 6 images in this plane. So for the midline sagittal image, so you will see the structure like this. So in this structure, this is the midline structure, midline sagittal view. So over here you will see this black anechoic area. So this is the cavum septum pellucidum filled with the CSF, and around that you will see this C-shaped or comma-shaped structure, which is regular from the front all the way to the posterior. So this is the corpus callosum. Then you will see this area. So this is a small little notch. So in this notch is called the cordothalamic notch, and this is the area of the thalamus, and the one which is just next to this comma-shaped anterior part is the caudate nucleus. So if you come down over here, so you will see this is the cerebellum, and right in front of the cerebellum is a small little anechoic area. This is the area of the fourth ventricle. If you look at over here, there's another small little anechoic area. So this is the third ventricle, and there's a small little echogenic area. This is the choroid plexus in the third ventricle. So if you look at over here, this is the cerebellum, and right below the cerebellum, you will see the area of cisterna magna. So these are all the important structures which you need to recognize when you are scanning in the midline sagittal plane. So these are very important that you should identify these structures, and you see the normal anatomy of these structures. So if you look at over here, right above the corpus callosum, so this is the corpus callosum. Right above that, you will see this echogenic line. So above this, this anechoic, the hypoechoic area is the cingulate gyrus, and above that is the sulcus. So you can recognize this also because this is also very important to look at this cingulate gyrus when you are scanning in the midline plane. So now you will move your probe a little bit towards the lateral direction, and then you will see you will be at the level of the lateral ventricle. So if you look at over here, this is the C-shaped structure of the lateral ventricle, and you will see this choroid plexus which appears echogenic. This is the area of thalamus you see over here. So if you look over here, this is the cup shaped on the anatomy of the lateral ventricle. This is the gross anatomy structure over here. So look at the for any dilatation in the lateral ventricle. You will also see some echogenic area close next to this lateral ventricle. So this is called the periventricular white matter. And always remember that this periventricular white matter should not be more echogenic than the choroid plexus. So it should always be less than the choroid plexus. So one more important thing, that if you remember that the choroid plexus is seen at the junction of the anterior, posterior and inferior horns. So this is the area. So we are at this area, we are at the area of the trigone or the atrium. Now further angulation of the transducer laterally, it results in a section which is lateral to the lateral ventricles. So in this image you will recognize this Sylvian fissure, which is the landmark for this view. So you have, if you see over here, you will also see the periventricular white matter. So you will see the white matter of the brain, Sylvian fissure, and you will see that the Sylvian fissure which divides the parietal lobe from the temporal part of the temporal lobe. So in routine, the intracranial ultrasound is done from the anterior fossa, which is by performing both the coronal and the sagittal plane images. You evaluate the entire anatomy. The posterior fossa approach also plays an important role, especially in the diagnosis of the intraventricular hemorrhage, by both to confirm it or to rule it out. This is especially when you see that the ventricles are not dilated. The posterior fossa sonography also provides the useful diagnostic information on the congenital cystic malformations and the infections in the posterior fossa. Now, if you look at over here, this is this image shows the parasagittal, which is the parasagittal view taken from the anterior fossa. So this shows that the choroid plexus appears a little bit echogenic or not, but this is very inconclusive. So on a parasagittal view, you are not very sure about whether the bleed is there or not. So so in such situations where you are not very much sure, so in that cases, if you just look through the posterior fontanelle, so look at over here. So from the posterior fontanelle, the parasagittal view shows you that the enlarged choroid with the heterogeneous echogenicity due to the internal hemorrhage. So you can see that there are difference between the image which is taken, the parasagittal view which is taken from the anterior fontanelle, and then you took it from the posterior fontanelle. So you can say that the addition of the posterior fontanelle evaluation is this approach to the sonography will increase the examiner confidence in studying the neonatal brain. Now, the other windows are also used for the evaluation of the intracranial anatomy. So if you keep the probe at the temporal part of the head of the neonate, which is right anterior to the ear, so you will see the appearance of the brain like this. So if you remember that this is the same appearance which you see in the calculation of the fetus BPD measurement. So this is the midbrain over here, you can see over here, and then this is the cerebellum, and these are the left and right hemisphere, and you can see the Sylvan fissure over here also. So this is the evaluation from the temporal lobe or the axial view of the brain. So if you turn your probe a little bit more superiorly, so you will see the cavum septum pellucidum also, and you can see these small tiny anechoic fluid filled slits, which are the ventricles, which are the anterior frontal horns of the lateral ventricle. If you angle more superiorly, you will see the left and right hemispheres. So these are the images which you take when you are performing the other windows, which is the temporal window. This is another window by looking through the mastoid fontanelle, which is right behind the ear. So by placing the probe at the mastoid fontanelle of the neonate, you will see that sweep the probe back and forth so that you can see the cerebellar peduncles. So look at over here, these are the cerebellar peduncles, and right over here is the central part is the cerebellar vermis. You can also see the fourth ventricle in this image. You see over here, this is the fourth ventricle, and look at over here the posterior part, which is the cisterna magna. So from the mastoid fontanelle window, you can see very nicely the cerebellar and the cisterna magna. So these are just the additional windows just for the further evaluation of the structures which you would like to see more. Now in this slide you will see that the extraaxial fluid space is evaluated, and for this you will use the high frequency linear probe which is used for the detailed visualization of the superficial structures, such as you can see the meninges, you can see the arachnoid and the subdural space, you can see the cortex. So for the assessment of the extraaxial fluid space, you take the width of the subarachnoid space, which is measured on the coronal views through the anterior fontanelle, and you will see for the evaluation of the subarachnoid space, you will have to use a lot of good amount of gel over the anterior fontanelle. This is because you are looking at a very superficial structures, so you need to avoid the pressure. So if you look at over here, this is the craniocortical width over here, and in this small little dot area is the sinus, and so the width from sinus to the cortex is the sinocortical width, and this is the craniocortical width, and then this is the interhemispheric fissure, and so left and right sides of this is called the interhemispheric width. So you take all these calculations and then you also need to compare both the left and right side spaces. The upper limits for the sinocortical width is that it should not be more than 3.3 millimeter, and for the craniocortical width is 6.3 millimeter, and the interhemispheric width is 8.2 millimeter. So these are the upper limits of the normal. The Doppler also plays a very important role in the evaluation of the intracranial anatomy. The most important and the commonly used approach of the Doppler evaluation is in the coronal view. So if you see over here, this is the image where you can see the fissure, and you see this star-shaped structure, and you can see the cavum septum pellucidum also. So when you see this star-shaped structure, and when you put the color box color Doppler on, and you put your box over here, so you will see this very nice cerebral arteries, which is the middle cerebral artery, this is the anterior cerebral artery, this is the posterior, and this is the middle cerebral artery, right middle cerebral artery. Even if you cannot evaluate the rest, but the middle cerebral artery is a bigger artery, and you can very easily recognize the arteries. So this is the area where you can see the circle of Willis. The role of color Doppler in the midline sagittal view. So when you see this midline sagittal view, this is the as I mentioned previously, that when you see this cavum septum pellucidum and the corpus callosum over here, and this is the cingulate gyrus. So when you turn on the color Doppler, so you put your box in this area, so how many important structures you will recognize in this image. So this is the anterior cerebral artery, and it is forming the pericallosal artery over here. So this one structure is the vein of Galen. And so this is very important also in pericallosal artery, because it gives you the that you can the regularity of this artery helps you to rule out the agenesis of the corpus callosum. So whenever you are looking for the arteries and veins or vessels in the on the color Doppler, always look for any vascular abnormality when you are scanning for the when you're scanning the neonatal head. Now this image shows you the superior sagittal sinus, and for the evaluation of the superior sagittal sinus, you use a high frequency linear probe which is placed in a coronal plane in the anterior fontanelle, and you identify so you put your probe at the anterior fontanelle and you identify the superior sagittal sinus, this is small little black area. Now if this should fail, reduce the amount of the pressure, because maybe you are pressing the too much pressure on the scalp, so that due to which it is collapsed. So you put a light pressure on the head, on the probe, on the to the fontanelle, and when you turn on the color Doppler, you will see this structure which fills up with the color. So this is the superior sagittal sinus. So this, if over here, this is the superior sagittal sinus, but now you are evaluating it in the transverse, in a longitudinal, in a parasagittal view. So this is the sagittal view of the superior sagittal sinus. So Doppler color ultrasound offers the possibility of detecting the cerebral sinovenous thrombosis at an early stage and creating a window for the therapeutic intervention prior to the thrombosis-induced tissue damage. Over here, the use of spectral Doppler, the anterior fontanelle approach is the most common site which is used for the to look for the circle of Willis arteries. So look at over here, we are taking the spectral Doppler waveform at the middle cerebral artery. The resisted index of major intracranial arteries ranges from 0.6 to 0.8. Now, spectral Doppler also plays a very important role in the diagnosis and the follow-up of the brain damage secondary to the ischemia, hemorrhage, infection, developmental disorders, and other conditions and other pathologies. Now we will just look for some of the abnormal cranial ultrasound images. So if you look at over here in this image, this is the grayscale image, and you see the big anechoic areas. You can misdiagnose it or misinterpret it as in a dilated ventricle, but now look at the importance of the Doppler role over here. When you turn on the color and you found that this is not a dilated ventricle, it is actually the arteriovenous malformation. So that's how whenever you see any anechoic structure, fluid structure in the brain, so always put the color on that structure in order to rule out any vascular malformations. So if you look at over here, this is the sagittal view and this is the coronal view. So look at over here, this is the small little echogenic focus over here, right at the chordothalamic notch. And this is the choroid plexus. So this is an abnormal finding. So if you look at over here, this is the normal. So put it on the so now you check it on the coronal view, and you will see that there is a irregularity, like asymmetric presence of this echogenicity. So this is the bleed on the left side. So this is the normal. This is the just to show you the normal structures. Now this slide shows you the corpus callosum agenesis with colpocephaly. So the typical findings of the corpus callosum agenesis, the coronal ultrasound through the frontal horns of the lateral ventricles. This will show you the widely spaced these lateral ventricles, which appears like a small little comma-shaped frontal horns of the lateral ventricle. So if you look at over here, this is the normal, and you look at over here, in the case of normal, they are lying close, but when there is a corpus callosum agenesis, you will see that these lateral horns are very far away from each other. Now, when you scan towards the posterior side, you will see that the trigones of both the lateral ventricles, they are dilated and they are very much parallel to each other. So this is the colpocephalic dilatation of the posterior horns of the lateral ventricles. Now, if you see it on the sagittal view, so in the sagittal view, you can see very nicely that the posterior horn and the level of the trigone, it is very much dilated. Another very classic finding of the corpus callosum agenesis is this, the indentation of the bilateral frontal horns over here. So you see there is indentation. So this indentation is the indentation of the medial indentation of the bilateral frontal horns. It will be seen on both sides. So this part which is indenting inside the ventricle. The colpocephaly is a congenital brain abnormality in which the occipital horns, or the posterior or the rear portion of the lateral ventricle of the brain, these are larger than the normal. Because the white matter in the posterior cerebrum has failed to develop, and these are all the classic findings which are seen in the corpus callosum agenesis. So whenever you see this kind of any of the this type of images where you cannot see the corpus callosum, like it over here, you cannot see the corpus callosum, so it is interpreted as the agenesis of corpus callosum. Now always remember that whenever you suspect the absence of corpus callosum, always document the images in the dual mode, in the coronal and the sagittal view. So if you look at over here, this is the agenesis of the corpus callosum. I'm just put the this normal image where you can just identify the difference between the two. So this is the normal, this is normal. This is the normal and this is normal, but this is the abnormal. So always put, whenever you find any pathology, put it in a dual mode where you can show both the coronal image and the sagittal image. Now, if you put the color Doppler on this image, you will see that there will be a agenesis and the absence of the pericallosal artery. So this is the normal, and look at over here. In the case of the corpus callosum agenesis, you will not see the nice pericallosal artery over here. Now in this slide, you will see that this is the normal, and you see very small little slit over here. This is the third ventricle. But in case of the third ventricle dilatation, you will see this is over here. You see it is quite dilated, and significantly enlarged third ventricle is seen in the trisomy 21 compared with the normal infants. If you look at over here in this slide, this is the normal, and look at over here. This is the coronal view, this is the sagittal view. You see the entire lateral ventricle is very much dilated, and with the hemorrhage, you see all this structure. So this is the hemorrhage along with the dilated lateral ventricle. This slide shows you the germinal matrix bleed. So if you look at over here, this is small little arrows. Look at over here, this arrow. So look at over here. These small little arrowheads point the echogenic areas, which are the bleeds, which are demonstrated both in the coronal and the sagittal views. So several clinical conditions are associated with the germinal matrix intraventricular hemorrhage, such as the hypoxia, ischemia, inflammation, cardiovascular instability, respiratory disease, so many more. There are many conditions which lead to the germinal matrix bleed, because germinal matrix is a very small vascular network, and which is very prone to rupture in case of fluctuation in the cerebral blood flow. And so this germinal matrix area is more commonly it is the area which is close to the junction of the caudate and the thalamic area. So caudothalamic junction is the common site for the germinal matrix bleed. Now this slide shows you the white matter or the periventricular injury. So if you look at over here, I told you that the periventricular white matter is always less brighter than the less echogenic than the choroid plexus. So when you see the any difference in the periventricular white matter echogenicity, whether it is equal to the choroid plexus or it is more brighter or more echogenic than the white matter, always evaluate such neonates because this could be the bleed over here. And look at over here. So this is it looks only echogenic, and the echogenicity is more like that of the choroid plexus. So this is the study which was done in the first week. So it is very important to document that to document on your report that the periventricular white matter echogenicity is increased, and it is increased or it is equivalent to the choroid plexus, because in such cases the follow-up exam is very much important. So now look at over here. This baby was followed up after the 10 days, and look at over here, it shows the cystic changes inside it. So this is the condition of the periventricular leukomalacia. Now the same baby then followed up later on. So this the cystic changes now change to the cystic and the cavitation. So look at over here. This is the grade 4 periventricular leukomalacia, where you can see the cavities and the cysts in this area. This slide shows you the intraparenchymal hemorrhage. So you see over here, this is all the intraparenchymal damage or intraparenchymal injury. So in this case, you see the intraventricular hemisphere. You see intraventricular line. The midline is also deviated. So it is very important to, if you see any structure which is deviating the midline, so always document it on your reports. Now a few of the this slide shows you over here, this is the birth related injury to the neonate. So you see that this is a big hematoma on the baby head, and you have to first document the exact location of the baby, the hematoma, whether it is parieto-occipital or temporoparietal or whatever is the location. And plus, when you evaluate this kind of image, when you see this type of structure on your exam, so always put a light pressure and plus put a little bit more gel so that you can see the skin and then you can see the scalp also. Because otherwise you can take it as a mirror artifact, so which is not right. This is a hematoma, and both the intra and the extracranial hematoma. So look at over here, this is the intracranial and this is the scalp, and this is the extracranial hematoma, and right above this is the skin of the baby head. This image shows you a very white, bright echogenic structure. This is the intraparenchymal hemorrhage. So look at over here. This shows the choroid plexus cyst. And this is, if you look at over here, you see the previous images where the subarachnoid space was very less, but now look at over here, the subarachnoid space is dilated over here. It is very much increased. So this is all about the neonatal intracranial ultrasound. These are some of the references which I used for the preparation of this video, and thank you so much.